வீடியோ அப்புறம் ரன் பண்ணணும்
சார். பிபிடியில் இருக்கா வீடியோ?
பிபிடியில் தான் இருக்குது, பட் அது வெளியே வந்து தான் ப்ளே பண்ணணும்.
இல்லை, இதில் பண்ண
முடியுமா? என்ன சார்? ஓ, அதில் வராது. ஓகே, இதில் வரும். பேக் இது அப்படியே. ஓகே, இதில் வராது. செட் வெளியே வந்து தான் வர முடியும். ஓகே, we'll see. Okay. Okay, go to slide view. Pointer. He was invited nationally and internationally as a guest speaker to conduct workshop in regional eye blocks and to perform live demonstration of ophthalmic blocks. He is also the chief editor for the book titled Principles and Practice of Ophthalmic Anesthesia. His areas of special interest include regional ophthalmic anesthesia, pediatric anesthesia, patient safety and biostatistics. He has won Best Free Paper Award for 3 consecutive times at the 3rd, 4th and 5th WCOA held at Turkey, India and Indonesia respectively. Over to you, sir. Thank you for the nice introduction. So today's topic I will be talking about the regional ophthalmic blocks. The ocular anesthesia as such can be divided into regional and general. The regional can be divided into akinetic and non-akinetic. The akinetic, where the complete globe akinesia has been achieved, can be achieved in two techniques. One is called as needle blocks and the other one is a cannula block. So today we will be seeing mainly this needle blocks and cannula blocks. First and foremost, we will see the technique of needle blocks. Now, I think that traditionally this is what has been practiced age old. Traditionally fractionated blocks, that is first block they used to give at the inferolateral quadrant, that is medial 2/3 and the lateral 1/3, and the second injection will be given at the superomedial quadrant. If you go through the previous standard textbooks, many standard textbooks quote this one, but unfortunately both these sites should not be given. So this is what the latest recent update in regional ophthalmic anesthesia. So what is going to happen if you are going to enter at the traditional point, that is at the 2/3 and 1/3, you see there lies the structure inferior rectus muscle. So what is going to happen is that there are many literature evidences which clearly states that the patients may go in for diplopia if you are going to enter at the traditional point. Here we can see there are many case reports of fibrosis of occurring of the inferior rectus and inferior oblique muscle. And here we can also see that MRI evidence following peribulbar anesthesia, muscle getting damaged with muscle edema following the traditional point of entry. Apart from this, there lies the neurovascular bundle which supplies the inferior oblique muscle. So if we see the latest current journals, what is a safe point to enter or to administer that inferolateral quadrant is that extreme inferolateral corner, that is you have to palpate the lateral wall and the floor just above the junction you should give, and this is what I have shown it as a star shaded shape here. What is the advantage? It's a nice avascular area filled only with pad of fat, there won't be any resistance at all, and theoretically speaking they say that this space is well connected to the intracorneal space. Now moving on to the second supplementary block which many of the postgraduates still tend to follow it, that is superomedial quadrant block. Why we should not follow? As you can see here, the globe is closer to the roof here. So the frontal bone overhangs here. There is much least space I can say available here, whereas at the inferolateral space there is more space available and there are many instances of globe perf occurring. Here is an interesting article that is published long back in Indian Journal of Ophthalmology 2007, where they were retrospectively analyzed 19 cases of globe perf. As you can see here, if the break is at the inferotemporal, the predisposing factor is myopia. You can go through here the 19 cases. Inferotemporal means myopia is there, whereas with superonasal block or perforation you can see there is no myopia at all, which means that patients with normal axial length itself
superomedial block per se can result in globe perf. So, they say the risk factors for perforation first is myopia, followed by block at the superonasal quadrant. Also, if we see, this is the superomedial quadrant is the most vascular one. Here are some of the hemorrhages happening, and as you can very well appreciate the point of entry at the superomedial quadrant resulting in complete ecchymosis and hemorrhages happening to the patients. Imagine the patient is a single-eyed patient, then definitely you will not be going to have a bad time only. And here we can see the complete aspiration of the gush of blood in the syringe. So, it is the most vascular as well as globe damage is also occurring here, and theoretically speaking there are chances of damaging occurring to the superior oblique muscle and trochlear apparatus too. So, what is the safe site that has been recommended now is medial peribulbar block, that is administered with a 26G half-inch needle that is passed between the blind pit and the caruncle and the canthal angle. Shortly I will be sharing a small video where you can understand much better. The depth of the needle passed can be somewhere around 15 to 20 millimeter. What are the advantage? Apart from acting as a supplementation to the primary block, it produces a nice eyelid block also. You can see the upper eyelid drooping down if we are giving in the right plane. And moreover, it is a nice avascular area. The globe is far away from the needle here, and it is just an half-inch needle. Now, coming to the intracorneal technique, that is, this is what is called as retrobulbar, which has now become absolute in practice now. What is the advantages? They say it is a quicker in onset because we are giving the local anesthetics just near the ciliary ganglion. So, thereby naturally the block should act fast, and since the block is acting fast, the local anesthetics required is lesser volume, and they say that less rise in intraocular pressure. But since we are angulating the needle to depth behind the globe, what is going to happen? The needle tip can hit the vital structures behind the globe, mainly the optic nerve and the ophthalmic vessels, resulting in systemic complications, orbital complications, and there can also be incomplete eyelid akinesia. So, this is some of the important point you should remember for retrobulbar block. And in retrobulbar block, what is happening? The needle tip is placed behind the globe, that is inside the muscle cone. Now, coming to the extracorneal or the peribulbar, as you can appreciate here, the needle tip is placed outside the muscle cone, that is just parallel or tangential to the globe. What are the advantages? Since the needle is not passed too deep, naturally the orbital and systemic complications will be reduced, but there are some disadvantages. They say that it acts little bit longer when compared to retrobulbar. Now, moving on to the next technique, that is cannula, that is subtenon's block. Subtenon's block, half late it is gaining popularity in all over abroad and also in India. What are the advantages? First of all, before going to the subtenon's block, a brief anatomy we can look into it. That is, the subtenon space is nothing but a virtual space that surrounds the eyeball between the sclera and the tenon's capsule. Now, this tenon's capsule is a facial sheath that surrounds the eyeball, and anteriorly you can see here it merges with the conjunctiva just behind the limbus, whereas posteriorly it fuses with the meninges around the optic nerve. This is a virtual space. So, how to enter this space? This space is entered with a blunt tipped cannula. So, the blunt tipped cannula that itself per se says it has added advantage when compared to a sharp needle one, which is a blind technique. Now, what is the technique to be followed? Instill a local anesthetics eye drops, that is proparacaine. Then the most preferred quadrant is the inferonasal quadrant. The fused conjunctiva as well as the tenons are gripped with the non-toothed forceps. Then using a Westcott scissors, you make a small nick into the conjunctiva and the tenon's capsule. Then with the closed scissors you should enter, so that we are creating a space up to the equator. Then do not open the scissors, just come with the closed scissors outside. Then you can insert the cannula that is fixed to a syringe containing local anesthetics, and you can inject about 3 to 5 ml, you can say. What is the mechanism of action here? The local anesthetics direct action on the short ciliary nerves that traverse the subtenon space. So, local anesthetics goes all around the globe circumferentially, and Some of them they say that it spreads forwards into the facial planes around the orbicularis muscles also, and eyelid block also can be obtained if more amount of local anesthetics is injected into the correct subtenon space. So what are the advantage? Lesser pain, lesser complication, because it is a semi-blind procedure and the cannula is a blunt tipped one, and they say that there is a decreased intraocular pressure when compared to needle blocks, and the eyelid echinacea also can be obtained. But some of the relative contraindication I could say, that is, it is not suited for repeat, especially retroretinal surgeries where there will be some amount of scarring, and naturally when compared to needle blocks here the complete echinacea will not be achieved. Still some movements will be there, but it depends upon the surgical skills to complete the surgery finally. Video. Now this video. So, yeah. Or VLC media player, you can merge. Close, VLC, VLC, okay, okay. So before giving block, it is very important to go through the files, examine the patient briefly, and completely explain the procedure what you are going to do. That is very, very important. IV line should be secured. Connect the patient to the monitor. This is that 23G 1-inch steel needle I am using for the peribulbar block. Okay. And also identify the site of the eye, that is very important. As you can see here, I am going to perform left eye block. So left sticker is there. Then cleaning the skin, palpating the lateral wall as well as the floor, and just above the extreme inferolateral quadrant I am performing the block. This is without any sedation, okay, and you can see the patient is very well comfortable, and I am passed the 1-inch up to the needle hub junction, aspirate it and inject the local anesthetic slowly. If you are in the right plane, you can see the upper eyelid completely drooping down nicely. Then withdraw the needle along the plane of line of insertion, give a nice digital ocular massage. Now before performing supplementary injection, again it is very important to again grade the efficacy of the block. Here we can see it is almost acted, but still some medial movements are there. I am going to perform the medial block. This is the 26G half-inch needle. This is the caruncle and the canthal angle. Drop the needle perpendicularly between the caruncle and the blind pit. That's all. It's a very simple way to administer the supplementary block. Aspirate, and then you can give 3 to 5 ml of injection. Come to that slide. Quit. PPT. Close. PPT. That's all. Okay. Close. Slide view. Sorry for starting in the middle again. Just it's a recap you can mean. So cannula block as I have completed, the needle blocks I have completed. Finally coming on to the, now if you want to go more about that regional ophthalmic anesthesia, you can get into this book. It is available in Amazon, Principle and Practice of Ophthalmic Anesthesia. And to know more, we also have a 3rd National Association of Indian Ophthalmic Anesthesia Conference coming in Hyderabad, October 7th and 8th. So please do join us. Now take home message will be a thorough anatomical knowledge of the globe, orbit and its contents is very important before you are performing needle blocks or cannula block. No single mode of anesthesia can serve as an universal choice for all patients and all surgeons. The technique mainly depends upon the balance between the patient's wish, operative need of the surgeon, skill of the anesthetist and type of the surgery. Both surgeon and anesthetist should work closely as a team. One should render a helping hand towards each other in enabling these visually handicapped patients to see the world like this. Thank you all. Thank you.